This is the first again of monthly webinars we thought would be very helpful to do this year and beyond. You all know this year would be a year to remember for years to come, and not in a good way. Our lives have changed in so many ways, and we learned to do so many things, sometimes more efficiently, and connect with people in ways we never did before. So this is one way I thought we can continue to connect with our community. Some of you already attended some of the mini lectures. My partners and I did different locations in this community, in the city and outside the city, raising awareness on different occasions about different disease states. We thought it's worth starting this at this level so you can join us from the comfort of your own home, and we can join you, and it will be an interactive way of communicating with everybody and discussing a topic of interest to those who are participating in these webinars. So the purpose of this is to be relaxed, to be interactive, and hopefully to be beneficial to you all. Don't feel sorry for me. I know it's cold outside. I'm not sitting outside, but the background is basically, this is the new Baptist hospital that we hope to see and occupy by 2023. So let's get started. This is just a reminder for me that number one, to thank you for calling in and getting connection to participate in this webinar, but also going forward, instead of calling to register in the future, we will be sending you an email that you can communicate with us through the email. So you can send the email and we can send you the Zoom information so you can communicate with us. What is the purpose of this and future AFib monthly webinars? These are my thoughts, but of course you can give us your feedback and I can adjust that accordingly. Number one purpose is to raise community awareness about atrial fibrillation, to be the trusted source for learning about atrial fibrillation, and to provide free interactive platform with experts in the field. Of course, we'll provide free answers to your AFib-related questions. Yeah, if you have personal problems, don't ask me about them, but AFib-related questions, I'll be happy to answer, my partners and I. And also, soon we'll be providing you with an email that you will post your questions using that email, and we'll do our best to commit to answer every question. And most importantly, we're going to be learning from your feedback for us to optimize the care we provide to patients with atrial fibrillation. Before going any further, here in the room with me is Patrick. Let me see if I can see Patrick. Here's Patrick. Patrick can wave actually without using the animation. Patrick has been the guy behind all these efforts and making it happen, and he's the guy you're communicating with to register and you'll be communicating with in the future. So we can't be more grateful for having Patrick and people like Patrick. Okay, now Patrick, let's get going again. The mission of Baptist Heart and Vascular Institute is to be the trusted partner for comprehensive cardiovascular care, which is certainly is aligned with the total overall mission of Baptist Healthcare, which is helping people throughout life's journey. The trust is earned, and we really hope we'll earn your trust. And before going any further, I would like to introduce you to our team that will be working very hard to earn and maintain your trust. These are the 4 board-certified electrophysiologists. The years under each picture is not our date of birth. This is the year we joined the Baptist organization. I was the first to join in '99. Dr. Verma joined in 2002, Dr. Gudrimus in 2013, and most recently, Dr. Hernandez in 2019. Some of you may already know or have one of us as your physician. Our team also is supported by 4 dedicated advanced practice practitioners, Mr. Watson, Berg, Baker, and Anderson, all of them dedicated to EP care, and combined they have more than 60 years of clinical experience. When it comes to the physicians, we have more than 50 years of combined clinical experience. If you look at the EP staff, this is almost the vast majority of them. We could not get everybody in the picture. And this picture was taken before COVID, so don't worry about social distancing. What's unique about EP staff, they are 100% RCES certified. That means they pass the test called Registered Cardiac Electrophysiology Specialist. Minority of labs in the nation can claim to have 100% certification for their staff. And we can be even brag further and say, few of our staff are IBHRE certified. This is the highest level of certification for any staff who is non-physician, and more are working towards this goal. We are the area's first heart rhythm center. I think 2013 or 2014 we started it. What that means, everyone who works in that center dedicated to taking care of patients with arrhythmia, only arrhythmia. And you can imagine doing the same thing over and over again, grow in the same field. You will be more likely to be the expert in the field than those who handle different kinds of medical problems. This is also part of our team in the Heart Rhythm Center dedicated to patients with arrhythmia. We are the area's first and only AFib center. As we will know during the rest of this talk, atrial fibrillation is a major issue, and it's a major focus of our arrhythmia management, and it's a major portion of our patients. So we have a multidisciplinary clinic. You can see us, the physicians, our physician assistants, the nurse practitioner, and you can see on both sides we have the AFib coordinator, and Dr. Lundquist is actually the cardiac surgeon on the team. It takes a huge team with different specialties and different level of interest and focus to manage patients with atrial fibrillation. It is a significant problem, and the solution is not that easy, and hope to learn about it today and in future webinars. It's one thing to feel great about where we are and to feel good about ourselves, but I think it's much better when others justify that feeling and give us objective evaluation of that. In 2016, we were one of the first 8 hospitals nationwide to achieve accreditation in the 3 areas of electrophysiology: testing and ablation, device implantation, and the chronic lead extraction. Those who may know people with devices, sometimes they get infected and they need to be taken out. It's a complex procedure. So in the 3 areas, we were only one of 8. And if you don't think it's a big deal, it is a big deal. Actually, we did put Pensacola on the map as a result of that. And because it's a big deal, in 2017, those 8 hospitals were recognized at the National Heart Rhythm Society Scientific Annual Session in 2017. And you will not see, but this is the team here representing us Baptist, and you can see Dr. Gidrim is here, head and shoulders above everybody else. That's how we feel. 2018, because of these achievements and more, we were highlighted in the cover page of EP Digest, which is the national EP magazine distributed throughout the nation. And Steve Pala, the director of the CAT and EP lab, wrote this article and did this interview highlighting our program and how unique it is and the quality it provides to the patients. It didn't stop there. In 2019, just last year, we were the cover story in the same magazine. Dr. Verma wrote the article highlighting our approach, adopting a strategy of early ambulation and same-day discharge for atrial fibrillation ablation cases. Patients with atrial fibrillation get the procedure and they usually stay overnight. We evolved into an efficient, safe way of doing the procedure and discharging the patient the same day. That was highlighted as a very safe, efficient, convenient way for everybody to do it. And we were highlighted, as I told you, as a cover story in 2019. This year, we had a follow-up to show our data and share with our colleagues throughout the nation. And this was in August of 2020, and you can tell this was this year. Very simple clue, all the masks around. So the reason I spent a few minutes highlighting our team, because again, I want to have your confidence that you are learning from those that they consider themselves and recognized by others are the best in the field. Now let's get to the topic of our discussion, and let me summarize the learning objectives of today. Today, we're going to learn about atrial fibrillation prevalence, the risk factors for developing atrial fibrillation, the symptoms that may indicate that you or somebody you know may have atrial fibrillation, how to diagnose atrial fibrillation, the association between atrial fibrillation and stroke, and what can we do to reduce the risk of stroke in atrial fibrillation. If you have more aspects of atrial fibrillation care in mind you would like to learn about, or you hope you would listen about today, don't be disappointed because you cannot get everything in 1 hour. And as I mentioned earlier, the purpose of this is to be relaxed, slow learning, interactive platform. And hopefully you will join us in future webinars. And by the end of the year, you'll be an expert in the field and we may hire you to work with us. So why are we picking up atrial fibrillation and why are we spending this time this evening and future evenings? Atrial fibrillation is a problem and it's not a trivial problem. It affects general population, high percentage. 4% estimated in this study of people in the hospital have atrial fibrillation. We expect that number to be much higher nowadays. Patients with congestive heart failure are very likely to have atrial fibrillation, and it's estimated up to 40% of patients with congestive heart failure will develop atrial fibrillation. It is a problem that happens with aging. It's more common in men, but it is more common as we get older. The way I tell my patients to think about atrial fibrillation, think about it as wrinkles and gray hair. The older you get, the more likely to have them. One difference here, Botox will not help you. It can happen in structurally normal and diseased hearts, and it is associated with significant morbidity and mortality. So let's go to another practice session here with the show of hands. We're going to try polling question here. Okay. The question is, raise your hand if you know anyone with atrial fibrillation. That someone could be you. And Patrick, I think, is working on it. We're good? It's not here.
It showed up on my screen.
Okay, so you can answer the question. I don't see it on my screen. All right, now I see it. Okay, so do you know anyone, including yourself, who has atrial fibrillation? That's the question. You just answer it and submit it. Again, we'll get more sophisticated with time, so bear with us.
18 yeses and 0 no's. 21 yeses, 0 no's.
21 yeses, 0 no's. Well, wow, that's impressive. So the prevalence of atrial fibrillation, it's estimated that about 3 million people have atrial fibrillation today, and that number is expected to double by 2050. And actually, the more recent estimation is millions more. It's a major problem. Here to emphasize that atrial fibrillation is a problem that more prevalent with age. If you look at the age here, younger than 55 and greater than 85 years of age, the prevalence or the percentage of patients or people with atrial fibrillation, red, women, blue bars, men. The older we get, both of them are likely to be affected with atrial fibrillation. By the time we are older than 80, 10 to 15% of patients, just by being older than 80, will have atrial fibrillation. So don't be surprised if you have atrial fibrillation if you're in your 70s and 60s or 80s. As you see here, men are more likely to have atrial fibrillation than women. I have a theory about that. I think women cause men to have atrial fibrillation, but I have no scientific evidence for it. When we look at the heart and we think of the heart, I hope this will. We always think of the heart as a heart pump. And you can see on top of the heart pump on the surface, the arteries and the veins, and those who have bypass surgeries bypass those arteries. The focus today would be on the electrical system of that heart pump. So if you look on the top here, you have these two chambers that are squeezing. They squeeze together and they pump the blood with every squeeze to the bottom chambers of the heart. The bottom chambers, we call ventricles, receive the blood from the top and pump it out to the lungs, the brain, and the rest of the body through these major arteries we call the great vessels. So keep in mind that the bottom chambers that pump the blood to the lungs and the rest of the body and responsible for providing us with the amount of blood we need to function and not feel short of breath, pump the blood that they receive from the top chambers. The less they receive from the top, the less they pump out. They are at mercy by the amount of blood they receive from the top chambers that we call atria. When we slice the heart while it's beating, we can highlight that the top chambers, the atria, are pushing the blood through the valves. You probably heard name of the mitral valve on the left. This is where facing the heart. And this is here on the right, the tricuspid valve. And you probably know somebody who had that valve replaced, the mitral valve. So you have the blood coming from the top to the bottom. The blue blood on the right side, that's deprived of oxygen, pumps the blood to the lungs. The oxygenated blood coming from the lungs is pumped to the rest of the body through the big aortic vessel here. As I mentioned, the top chambers we call atria, the bottom chambers we call ventricles. So you can guess atrial fibrillation is a problem of the top chambers, but it has consequences on the bottom chambers. The bottom chambers at mercy of what they receive from the top. If the top has a problem, the bottom will suffer from it. Atrial fibrillation is an electrical problem with mechanical or hemodynamic consequences. This is the representation of the electrical wiring system of the heart, if you will. The electrical generator of the heart is located in the top of the right top chamber of the right atrium. That signal starts from the top and goes to the bottom through electrical wire, if you will, or cable that splits in half. One goes to the right and one goes to the left. And that's how the signal travels from the top to the bottom chambers. The heart as a muscle cannot beat without electrical activation. So each heart has its own electrical pacemaker. If we take the heart of the frog out of the body and put it in a physiologic solution, it will keep beating. That means the heart has its own electrical battery, its own electrical generator. Atrial fibrillation is a disturbance in the top chamber of the heart, where instead of having one spot in the top chamber of the heart making the electrical signal, you have too many spots firing at the same time, competing and keeping that heart running so fast. Normal heartbeat can go normally at rest between 50 to 100 beats. That's the top chambers. So with every heartbeat, the top chamber is supposed to be beating together. 1 beat a second, 60 beats a minute. When you go into atrial fibrillation, the top chambers, instead of beating 1 beat a second, 60 beats a minute, the top chambers are quivering like this. And how fast? They are quivering at 300 to 400 beats a minute. Luckily, the electrical connection between the top and the bottom chambers does not allow 300 beats to go down. Otherwise, the bottom chambers will be quivering as well. And that will not be a good thing for the heart. It will basically stop. But it can drive the bottom chambers about 100, 150, 170, 200 beats a minute, depending on the patient's age or the person's age. So I hope now you have an understanding of what atrial fibrillation is. It's an electrical problem. It's localized to the top chambers, resulting from quivering of the top chambers because of many electrical circuits taking over instead of one spot in the top chamber taking over and causing the heart to beat. And this is side by side. On the left, you have a normal, healthy rhythm. Top chambers beating together. With every squeeze, they push the blood and fill the bottom. the bottom fill with blood and push the blood to the lungs and the rest of the body. When you have atrial fibrillation, the top chambers are quivering, going really fast, driving the bottom chambers fast. And you can see the difference in the EKG on the bottom here, nice regular versus very fast and irregular. This is normal rhythm. This is atrial fibrillation. So what are the risk factors for developing atrial fibrillation? I'm going to highlight some of them. Having a heart disease is not a good thing in general, and it will increase the risk for having atrial fibrillation. If the patient or the person has heart failure, valve disease, a leaky valve, especially severely leaking, or stenotic valve, that increase the risk of having atrial fibrillation. Blocked arteries, that increase the risk for having atrial fibrillation. Lung disease, people who smoke and have what we call emphysema or COPD or chronic obstructive lung disease, people who have lung clot or what we call pulmonary embolus, pneumonia. This is just few of the lung disease states that can cause atrial fibrillation. Hypertension, especially uncontrolled hypertension, can cause people to have atrial fibrillation. Overactive thyroid, that's an endocrine problem where the thyroid, which is the gland in the neck, responsible for our metabolism. If it's overactive, you can imagine pushing a lot of gas on that engine can get it out of control. Hyperthyroidism, that's why if you have atrial fibrillation and your doctor say, we're going to check your thyroid test, it's a blood test, that's the reason for that. Excessive alcohol use, caffeine, stimulants, drugs, all that can trigger atrial fibrillation. Don't ask me what's excessive alcohol. Ask a family member who doesn't drink if you drink excessively and trust their answer. That'd be my advice. Sleep apnea. Sleep apnea meaning you stop breathing, apnea, during sleep. How do you know you stop breathing during sleep? You can ask yourself either. If your family says you snore, you stop breathing, your spouse say you snore, you stop breathing at night. If you wake up in the morning with a headache, feeling tired, not refreshed, if you tend to nap throughout the day, chances are you have sleep apnea. And almost every patient who I see with atrial fibrillation, I ask him about those symptoms, and any suggestion that that person may have sleep apnea, I send them for a sleep study. Why? Because if you have sleep apnea and you're not treating it, the chance of success treating atrial fibrillation drops significantly. We double our success rate by treating sleep apnea. Having family history of atrial fibrillation, another risk factor. That's something you can't change. Does that mean if you have an atrial fibrillation and you are having kids, your kids are going to have it? No, but the risk of having it is higher than those without family history. This is just some of the risk factors I would like to highlight. Now, what symptoms do we get if we have atrial fibrillation, or what symptoms we may be having now that may suggest we have atrial fibrillation? We discussed that atrial fibrillation is an electrical problem of the heart where the heart is quivering, going fast and irregular. So we may feel our heart inside the chest, beating fast, beating out of the chest, having palpitations, a sense of flutter. I heard every description you can imagine describing that feeling of the heart being out of rhythm, out of control inside the chest. As a result of the heart going too fast, not allowing regular, healthy movement of the blood from the lungs to the top chamber, to the bottom chamber, to the rest of the body, not having enough time with the heart going too fast to fill with blood before it pumps it out. Remember, the pump, it has to be filled first before it allows the blood out. You fill with blood, then you pump out. You fill, then you pump out. If you're too fast, you don't have enough time to fill enough blood to pump out. As a result, that heart pump is not circulating the blood very well. So the blood gets backed up to the lungs and the lungs get filled with fluid, and that can cause shortness of breath. The blood is not pumped to the brain. the pressure dropping, we can be dizzy and lightheaded. The heart is going too fast. A pump is running too fast, needing a lot of oxygen, a lot of blood flow. We can feel chest pain. It can even cause heart attack if the heart going too fast beyond the ability of the arteries to provide that heart muscle with what it needs of oxygen. We may feel tired, of course, but one thing I would like you to know, that we may feel nothing. Asymptomatic, completely asymptomatic. Now, I would like to teach you something about EKG and how to read EKGs. Why? Because some of you already have or will have a smart app, an Apple Watch, some kind of recording ability to record that EKG. So let me explain it to you in a way I guarantee you, you will be able to read your own Apple Watch. Guaranteed, or your Apple Watch free. No, that was a joke. All right, so the heart is a muscle. We said the top part of that muscle had two chambers we call atria. The bottom part, two chambers we call ventricles. The muscle mass in the top, smaller than the muscle mass in the bottom. The EKG is a recording of the heart electrical activity. That's what it is. We are putting patches on the top of the chest, on the arms, on the legs, to record the electrical activity of that beating heart muscle. So the larger the muscle mass, the larger the electrical deflection or the signal it makes when it's recorded. So the top chambers are smaller mass than the bottom chambers. You can see the wall is not as thick. Why is that? Well, I'm going to teach you that too. The top chambers are simply pushing the blood from the top to the bottom. Look at that distance. Not that far, just across the valves, and pushing it with gravity. You don't need much muscle. That's why the muscle is not that thick. But if you look at the bottom chambers, you are pumping that blood from the heart, from the chest, all the way to the brain, to the rest of the body. You are lifting heavy weight. The heavy lifting is done by the bottom chambers. Guess what happens when you beat 100,000 times a day, lifting that weight every day of your life? You're going to get bigger and thicker muscle. And that's why this muscle is thicker. And as a result, you can imagine the signal from the bottom chamber muscle mass is bigger than that of the top. So when we activate the top part of the muscle, the atria, we get a small deflection. Don't look at the name, it's called P wave. That's for our reading capability. When we activate the bottom muscle mass, we get what? Bigger signal. So let's practice. This is an EKG you will see on your Apple Watch or any smart watch or your app. You can see squiggles, no question about it. You have big one and small one. The small one belongs to the top chambers, the atria. This big one belongs to the bottom chambers. Top chambers beat before the bottom. You got signal of the top before the bottom. What is this here? This has to do with the heart getting ready to receive another signal. So ignore that. Top, bottom, top, bottom, top, bottom. This is normal. When the top beat before the bottom, and every time the top beat, the bottom follow with 1-to-1 ratio, that's what a normal rhythm is. So next time you see that on the watch, brag about your abilities to read the EKG and say, wow, the small little one is the top chambers, the atria, and this is the bottom chambers. So this is a lesson in EKG that you may find very helpful, especially for those receiving all these gifts a few days from now. Let's practice again. This is the bottom here, and we have the top. We have different EKGs. The bottom, we have signals that are large and signals that are small. The small signals, top chambers, large signals, bottom chambers. We can also appreciate the bottom chambers that give us the pulse are beating at equal spacing intervals. That means it's regular pulse. And if you put your finger on the pulse on your wrist, you'll be able to feel regular pulsing, 1 a second or 60 beats a minute. If you look at on your smart watch and you see this, you can say, wow, this is beautiful. You look at the top, also not hard to see that the big signals representing the bottom chambers of the heart are beating. Beautiful, we have a heartbeat. But you can't disagree that this is very irregular. That's the clue. Number one clue, it's irregular. Number two, let's look at the top chambers, the little squiggles. Look how much, so much. In the bottom, every time the top beats, the bottom beats once. One on the top, one in the bottom, one in the top, one in the bottom. Here, you have 7 in the top, 1 in the bottom, 5 in the top, 1 in the bottom. That's why the top could be going 300 beats and the bottom would be going 100, 150, 75. So you could be in atrial fibrillation, but your pulse oximeter showing 70, 80, 90, 100. And you say, that's not 300. No, because you're checking the bottom chambers beating. The key then is the irregularity. How do we diagnose atrial fibrillation? Now we understand how to read the EKG. You can only diagnose atrial fibrillation with certainty, not by having a regular pulse, because there are so many things that can cause a regular pulse. Not by having a heart rate of 150, because there are so many reasons for your heart rate to go to 150. If you have a fever, if you're young, your heart rate can go up to 150. If you're exercising, your heart rate can go up. EKG is the gold standard. And let's practice again. Some of you have had those EKGs done, and look at the strip at the bottom. I think you agree with me that you can see those bottom chambers beating irregular. That means the space between each beat and the other is not the same. That's irregular. That's your clue, atrial fibrillation. And for those who don't have any symptoms in association with atrial fibrillation, how do they know? Well, a lot of patients I see, they are referred to me, they were getting ready to get colonoscopy, screening colonoscopy, and they do the EKG, oh, you have atrial fibrillation. You need to see your doctor. Or prior to other routine surgeries, or on routine exam. So those who may have no symptoms, an EKG done to evaluate irregular pulse, pre-op or during routine exam, diagnose it. We just talked about symptoms that could suggest atrial fibrillation. And as we'll learn, atrial fibrillation may not be there all the time. So if you finish this webinar and you go say, oh my God, I remember feeling my heart racing and fluttering once a day, 5 times a day, but it doesn't last more than 5 minutes, 10 minutes. Every time I go to the doctor, they do the EKG and they can't find anything. Well, in that case, we have other ways of monitoring your heart rate. So if your rhythm out of rhythm, or you feel something, dizzy, your heart fluttering, irregular pulse or oximeter you check at home a few times a day, then we can give you a monitor called 24-hour monitor, meaning every beat of your heart is monitored and recorded for 24 hours. Some of you may remember those annoying patches with a lot of allergic reactions sometimes, and this is now, simplified with a smaller patch. It can still be something you may not tolerate, but this is one way of doing it. So for those who have symptoms every day, it makes sense to monitor them for 24 hours. We look at every strip of those 24 hours and we see if you have atrial fibrillation, okay? How about those who have their symptoms once a week? Well, we'll give you a month-long monitor. Every time you feel something, you push on the button, and that will catch and capture your rhythm at the time of your symptoms, and we'll see if your symptoms because of atrial fibrillation or something else. How about for those who have symptoms once every 2 or 3 months, or the time they were wearing the monitor, nothing happened? Well, we have a solution for that. And that is a small monitor the size of a paper clip that has a battery that lasts up to 3 years, that we can implant under the skin with a small incision. This, 5 millimeter long incision under local anesthesia only. It's almost an office-based, possibly, procedure. Put it under the skin, and that will communicate with a transmitter next to the bed. Anytime you come within 6 feet of that transmitter, it will record and let us know if you have atrial fibrillation. So we have means of documenting whether you have atrial fibrillation or not. So now we know what atrial fibrillation is, how big of a problem it is. It is an electrical problem with mechanical consequences. We know the symptoms, and we know the diagnosis and how to diagnose it. These are the things you may be seeing. And this is one smart app. You put your fingers, and the phone will record the electrical activity of your heart. I think you all agree this is a nice, regular rhythm. Even Patrick here is shaking his head. He learned it. And this is on the Apple Watch. You can also see the heart rate is 111. That's fast. It doesn't mean it's atrial fibrillation, right? Look at the rhythm. Is that regular? Yes. Do you see a little signal before the big signal, each one? Yes. That's also not atrial fibrillation. So that's something also you can use to diagnose atrial fibrillation. I want to just highlight the quivering part of atrial fibrillation. This is a camera in a beating pig's heart filled with physiologic clear solution. This camera is looking inside the top chambers of the heart. First of all, you look at the top chamber of the heart. It's not all smooth and nice like you see on Valentine's Day. It's all trabeculated in many areas. So you can imagine why clots can form there. But you can appreciate, hopefully, the quivering mechanical movement of that top chamber. This is actual atrial fibrillation in an actual beating heart. Now let's get to the serious part. We said atrial fibrillation is a problem of the top chambers. This is one top chamber on the right, one top chamber on the left, bottom chambers. The top chamber on the left pushes the blood to the bottom chamber on the left that pumps the blood to the big aorta, which distribute the blood to the brain and the rest of the body. There is a pouch-like part of the left top chamber. We call it appendage. When the heart is quivering, and because of the location of that appendage and its size and how it's not moving the blood very well, the blood gets stagnating there and cause a clot to form. And this is another representation of that top chamber, bottom chamber, the valve between the top and the bottom, and this is the pouch-like structure I told you about. We call it left atrial appendage. That is the site of more than 90% of the clot formation in patients with atrial fibrillation. Remember that, because it will be relevant to what we're going to be learning over the next few minutes. This is looking at that top chamber and its appendage by ultrasound. This is a normal one, no clots in here, and this is the one with big thrombus, big clot. And this is an actual patient looking at the top chamber. This is the top chamber on the left. This is the pouch we're talking about, and this is a huge clot. Is it the usual way we have this kind of huge clot? No, but I assume you haven't seen clots. I thought I'll highlight it. The clot could be as little as a millimeter or a few millimeters. Why do we worry about it? Because if this clot or part of it breaks off, as it will if we don't treat it, goes to the bloodstream, and then it's going to be pumped from the heart to the big artery, and if we're unfortunate enough, it will go and cause a stroke. And that's the relationship between atrial fibrillation, creating clot that can break off and cause a stroke. And this is animation of that risk and fact. These are when the blood is not moving very well, the blood cells get together and decide to unite and cause a clot that's pushed between the top chamber to the bottom chambers. Remember, the bottom chamber is strong and they pump this clot. If it's unfortunate, it goes and causes stroke. Of course, it can go to the arm, it can go to the gut, it can go to the kidneys, to the spleen, the legs. And there are clots that are formed and go into the brain, but luckily to parts of the brain that are not significant, so we may not have weakness or problem with it. How bad is having a stroke? Well, in this study, they looked at a survey asking people what are they most concerned about when they have atrial fibrillation. and scared of. Stroke was by far, almost everyone, 91%. Distant second, death. And that's what I highlight to my patients. Some patients say, I don't want to take a blood thinner. I don't care. I'm ready to go. It's not the problem to be ready to go or not. It's the problem is we don't go. We get a stroke and we'll be living miserably for the rest of our lives. So stroke is serious, and everyone agrees with me, and that's a concern in patients with atrial fibrillation. Now I'm going to classify atrial fibrillation, and that will make you understand why some people have atrial fibrillation all the time or part of the time. When we have atrial fibrillation only part of the time and the episodes come and go, we call it paroxysmal. When the patients have atrial fibrillation and it's there, unless we shock the patient out of it or give them medicine or do ablation to get them out of it, we call it persistent. If someone has atrial fibrillation for more than 1 year, we call it long-standing persistent. If someone lives with atrial fibrillation and all efforts fail to get them back in atrial fibrillation, and the decision is made to live with atrial fibrillation for the rest of the life, we call it permanent. This distinction is important, and I'll tell you why. Atrial fibrillation is a major risk for stroke, and let's put some numbers to that. Atrial fibrillation causes 15 to 20% of all strokes combined, and up to 24% of strokes in patients older than 80. Having atrial fibrillation will increase the risk of stroke 5 times relative to general population with no atrial fibrillation. Strokes with atrial fibrillation tend to be more severe. Why? Because that clot is relatively big. So when it goes to the artery, it plugs and blocks the blood supply of a larger branch. Larger branch supplies larger area of the brain. Devastation is worse. The key point that the studies have shown, if you have atrial fibrillation, whether you're in and out of it or you're in it all the time, the risk is similar. So don't tell me I have atrial fibrillation yesterday, I'm fine today, I can stop the blood thinner today. If you have atrial fibrillation, you need to be on the blood thinner, and we'll talk about that. And whether you live with atrial fibrillation or we try to get you back in rhythm and give you medications that seem to be successful, as of today, you still need to be on a blood thinner. The key question, does everyone with atrial fibrillation need to be on anticoagulation or a blood thinner? Because from what we learned, atrial fibrillation can cause clot and the clot can cause stroke. But not everyone with atrial fibrillation benefit from being on a blood thinner. Who would benefit? There is a scoring system that goes from 1 to 9. That scoring system here, we call it CHADS FAS score. It's an acronym that gives 1 or 2 points to each of those disease states. If somebody has heart failure or weak heart pump, you get a point. Someone has hypertension, you get a point. Age older than 75, you get 2 points. Diabetes, 1 point. Stroke, 2 points. Vascular disease, meaning blocked arteries, neck artery blocked, leg artery blocked, 1 point. Older than 65, 1 point. Female sex, 1 point. So your score can go from 0 to 9. And the higher the score, the higher the annual risk of stroke. If your score is 8, you risk every year about 7% of having a stroke. 9, 15%, or even higher. If your score is 0, meaning you're young, let's say you're a 40 or 55-year-old with none of these risk factors, you don't need to be on a blood thinner unless you're getting cardioversion or getting ablation, and we'll talk about that in future webinars. If your risk is 1, your stroke risk per year is about 1%. And you see, the higher the score, the higher the risk. And that's where the recommendations came about, based on that data. You calculate your score. If it's 2 or more, you need to be on a blood thinner. Recent data from last year and guidelines, because we keep updating those guidelines based on data that keep coming in, they took the gender or the female sex out of the equation. But instead of coming up with a new acronym, they said, if you're a male with a score of 2 or more, you need to be on a blood thinner. If you're a female with a score of 3 or more, you need to be on a blood thinner. So if we have a volunteer, we can calculate, or you know what? Each one of you can calculate a score of a person he or she knows with atrial fibrillation, including oneself, and email it to the email we're going to send you with your score. And that will be a good thing to know if that person needs to be on a blood thinner or not. So assuming your score is 2 or more and you're a male or female and your score is 3 or more and with atrial fibrillation, remember, a lot of people ask, I have all these risk factors and I'm not on a blood thinner. You have to have atrial fibrillation and the score. Don't score yourself unless you have atrial fibrillation, okay? So we decided you have atrial fibrillation and your score is 2 or more for a male, 3 or more for a female, you need a blood thinner. What options do we have? Warfarin is an old option we use more than 50 years, but it has its limitations. Some of you know about warfarin or may have taken it. The issue with it, we cannot predict how fast it's effective, how fast it makes the blood thin enough. It can take a few days, it can take a week or 2. And what's the dose? It's variable among patients. Some people will take 5 milligrams, 7 milligrams, 10 milligrams, 15 milligrams. You have to keep repeating the blood test every week sometimes to figure out what's the right dose. And the dose could be very variable. Why? Because there are so many interactions with diet, like eating greens or other drugs, a lot of interactions. So because of all these limitations, since 2010, we have 4 new blood thinners that are approved to replace warfarin. The first one was Pradaxa or Dabigatran, 2010, and the 3 followed, 2011, Xarelto, you see all these on TV, Eliquis, 2012, Ebaxiban, and Edaxiban, Ceveza, 2015. Nothing in use since. All these 4, when they first came out, everybody was hesitant to use them. They did not have antidote in case somebody bleeds. Now all of them have antidotes, so don't be too worried about them. And when you compare any of them and all of them collectively to warfarin, they are at least as effective. Actually, Pradaxa and Eliquis, they've shown to be superior to warfarin, but none of them is less or inferior to warfarin efficacy and safety. All of them have more favorable bleeding profile, same or less bleeding. All of them have less incident of bleeding inside the head, intracranial bleed. All of them, you take the same dose every day after the dose is decided by your physician, depending on your age, your weight, your kidney numbers. All of them start within a few hours and the action is over. Not basically days. It takes also, the half-life is about 12 hours. Very little interaction with food and other drugs, and you don't need to repeat testing every week or every month. How about for those who cannot take the blood thinner? Because every time they take it, they bleed. They bleed nosebleed that could not be controlled, stomach bleed, black stool, bloody stool. They do colonoscopy. They can't find the source of the bleeding. They had bleed inside their head. Then what options do we have? If we stop the blood thinner, I mentioned there's a risk of stroke. If we take the blood thinner, you already shown us, you're going to bleed on it. Well, we have something called non-pharmacologic option to reduce the risk of stroke in patients with atrial fibrillation in case you cannot take the blood thinner. By taking that pouch out of commission, remember that pouch, the left atrial appendage? We exclude it from the circulation. So when the clots are formed, they cannot get out. You lock the door on that pouch. The 2 main options we have today, the first one is Watchman device. The other one is surgical ligation or clipping of that appendage. And that's why we're going to talk about next. This is for patients who are not a candidate for long-term anticoagulation. They may do well for short-term, but every time they take it for a few months, they bleed. Okay, this is one option. This is the plug, like a parachute. This is the appendage, the pouch I'm talking about. We go inside the heart with the sheath, and through that sheath, we let this device come out and expand and plug that opening. And within 6 weeks, the body will cover that device with its own tissue. And now we excluded this pouch, and all the clots are trapped and they don't come out. And studies have shown, and real-world experience have shown, that this device will provide protection similar to the patient being on a blood thinner. Of course, as you would expect, with much less bleeding complications. Why? Because you're not on a blood thinner anymore. But you will need to be on the blood thinner for a short period of time until the body cover that device with its own tissue. And this is one patient we did looking with a 3D ultrasound at the plug after we put it inside the heart. We do this routinely. We started doing this 4 or 5 years ago. And actually tomorrow, we have patients to be done in the morning. How about for those who can't even take that Watchman device? Because as I mentioned, Watchman device, you need to be on a blood thinner for 6 weeks. After that, aspirin and Plavix for 6 months until the body covers that device with its own tissue. Some patient cannot even take those few weeks of blood thinner without bleeding. Well, that's when we have the option of surgical clipping or ligation. So this is the appendage from outside. And these clips, like a bag of chips clips, they are just way more expensive because they are still sterile and medical, and they come in sizes. Outside, you hold that appendage and you put the clip at the base. You close it. From inside, it looks like this. So this is left atrial appendage clipping. And this is the ultrasound looking at the top chamber, the bottom chamber, the valve between the top and the bottom, and this is the pouch we talked about. This is before the clipping, this is after the clipping, gone. No place for the clots to be formed. Now I want to give you a test to tell me what represents sinus, noise, rhythm versus atrial fibrillation. I don't know how to answer that questions for you. Okay, with the raise of hands, who thinks this is sinus? Nobody raised their hands? No hands. So even voting here is rigged, huh? Well, tell you what, this looks to me like sinus. If I have to pick which is sinus, this is atrial fibrillation, disorganized. Okay, I'll give you another test. Where is the sinus? Where is the atrial fibrillation? Any volunteer? You can unmute yourself and tell me, somebody.
AFib on the right.
AFib on the right, very good.
Agree.
Right.
Right.
Great, great, great. Wonderful. Poor guy, look how miserable he is with that AFib. Now, I'm gonna volunteer for this one. This is the sinus you wanna be and think of being in rhythm. And this is AFib, no synchrony, everybody on his own rhythm.
But I like the one on the left.
You like the one on the left? I'll keep it for you. Well, that ends our webinar for today, and what we learned about, hopefully, understanding what atrial fibrillation is, how to diagnose atrial fibrillation, the symptoms of it, how to read the EKG, and the most dreaded complication and associated risk, which is the stroke, and what means we have to reduce that risk, and how to calculate that risk score by using the CHAS-VASC acronym. And the future webinars will address more aspects and different aspects of the atrial fibrillation. We will provide you with your emails you provided us, an email for future webinars, And really what I care most about is your feedback. Let me know if we're too slow, too fast, what aspects of atrial fibrillation you're more interested in. We're finishing the hour here. I'm going to stick with 1 hour, so to respect everybody's time. I know you have a lot of questions. In the future, we'll make it less information, more questions. And you can send your questions to the emails you'll be provided, and we'll answer them next webinar, and also individually by email. And we'll have interactive sessions, not only with me, because you'll be bored if I'm the only one here. I'll give the next maybe 1 or 2, but we'll have my partners addressing different aspects of atrial fibrillation, talking about ablation, talking about bringing the staff members, the Heart Rhythm Center members, the AFib coordinator. What is the plan for you before atrial fibrillation ablation, after ablation? Who needs to get ablation? Who needs to get cardioversion? What's cardioversion? All aspects of atrial fibrillation. This is the first one here. I hope it was not a very bad one. And I hope you had as much excitement as I did, because I really enjoyed this. And if you don't enjoy it, don't tell me. Only those who enjoyed it send a message saying so. I'm very sensitive to negative feedback. All right. Thank you very much. And I want to wish everyone a very Merry Christmas, Happy New Year, Happy Holidays. More importantly, may your heart enjoy sinus rhythm today and forever. Good night.
Thank you.